So now another challenge is visual rehabilitation and follow-up after surgery. So moving on to Dr. Kalpana. Dr. Kalpana Narendran is the head of the department of the pediatric ophthalmology department in Aravind Eye Hospital, Madurai.
Coimbatore.
Yeah, sorry. Coimbatore. Thank you.
Thank you,
Over
madam.
to you.
Thank you for the opportunity. And it's so nice to see some audience. In the other hall, only five of us, and only five of us, but we
I'm
spoke
sorry for
religiously.
that.
No, no, I'm saying, no, this is nice, madam. It's, you can't take it
Getting
more
all
than
the
this.
best faculty and having only the speakers actually is very really
No, no,
sad.
no, it's nice
Thank you
to
for
at least.
being here.
So my topic will be visual rehabilitation post pediatric cataract surgery. We all know that when we see a pediatric cataract patient, what we tell the parent is just don't think that by doing the surgery it is over. By doing the surgery only 50% is over. The 50% is a follow-up and rehabilitation. Because not like in adults, you just remove the cataracts and they'll be fine. So we should always keep that in mind to counsel the parents regarding the rehabilitation and the follow-up. And we all know that the very important thing in the child is to get a good functional outcome. And following which you have to think about the rehabilitation to give, because children have longer living years. So we have to keep that in mind and don't do anything aggressively or don't make adventures in children. Where it's always better to be conservative. Only if something is time tested, proven, and you are good at it, attempt to do it. Because don't make blunders and make these children blind for their lifetime. And there is always this dilemma that when there is a cataract like this, bilateral mature, what you would do, and you should always keep in mind there is not one problem. One is it affects the visual pathway maturation. Second, stimulus deprivation amblyopia, and retards emmetropization. So all these, and also it affects the IQ and the development of the child. So it is definitely a complex problem. So first thing is to clear the opacity. You have to make the visual axis good and clean and make the child see. So the intervention, again, 4 to 6 weeks of age based on the unilaterality or bilateral. Unilateral, younger age, usually 2 weeks, the child is healthy, no other complications, you can operate. In bilateral cataracts, 6 weeks of age. This aphakic glaucoma, definitely there is an option, but I think as practicing pediatric ophthalmology, we would say that incidence has come down a lot. And even there is an IOP rise, we can always treat it with good medications we have now. And the post-operative rehabilitation, one is give a optimal visual stimulus. One is by removing the opacity. Second, by giving them aphakic glasses or contact lenses if the patient is compliant. In our setup, contact lens is not very well accepted unless the parents are very educated. And then intraocular lens is an option based on the case selection. Then followed by effective amblyopia therapy, because most of the children are going to present to you at a later stage. So amblyopia therapy should also be part of the rehabilitation program. And what difference is this IOL going to make these children? You are seeing here the thick aphakic glasses sometimes cosmetically may not be acceptable. The images will be big. Child will not have good peripheral vision. Will have to move his head for the field of vision. So this will give you a good quality of vision. For the patient, cost, I won't really talk about it here. But then compliance problem is not there. And but younger children, if you implant, definitely there is a problem because you have to think of resurgeries and good quality of life for child and the parents. But again, the downside is there are certain advantages that the child can regain the binocular single vision and maximizes visual outcome, cosmetically good and all that. But the disadvantages is visual axis opacification, myopic shift. Keep in mind that you're putting a lens in a growing eye. So always keep the myopic shift in mind. So that also can be a big problem. Sometimes you later on, if there's a gross myopic shift, you may have to go in for an IOL exchange, and it can also give some anisometropia along with your added stimulus deprivation amblyopia. So we should keep all that in mind. And the minimum age for IOL implantation, I already told you this, bilateral cataract, usually about 8-9 months of age, and unilateral, earliest is 3 weeks if the corneal diameter is more than 10 millimeter, no other associated pathology, and if the child is going to come for regular follow-up. If you put a lens and the child is not going to follow up, you're making more damage. If that child is a poor socioeconomic status, not going to come follow up, leave him a phakic. It's always better to leave him a phakic rather than putting a lens and creating more problem. And this is just a small surgery of how, pediatric cataract surgery. It's very simple. Like she said, if you treat them and do it the right way, usually the eyes are very quiet. And the only thing is the capsules, it's not a miniature adult eye. That we should keep in mind. Because the capsule is much elastic. So if you're wanting to do a 5.5 mm, you have to be very, the way you do it is a little different. And thorough cortical cleanup is very important. If you leave behind some cortex, there is a possibility that the PC fibrosis can be much faster. So that's very important to do a thorough cortical cleanup. And a primary posterior capsulotomy, which we normally don't do in adults. So that is very important to keep the visual axis clear, especially children below the age of 8-9 years. Just doing a good cataract surgery does not suffice. You should do a good primary posterior capsulotomy with anterior vitrectomy. That is very important. And it's better to suture the wound. Once in children, because they'll rub their eyes, and especially when you do a vitrectomy, always close the wound with a 10-0 vicryl suture, which usually you don't have to remove, but sometimes if it causes irritation, then some debris the child develops like infection, then you have to remove it. Then the primary posterior capsulotomy is indicated, like I said, above the age of 8-9 years. You just do the rhexis, don't do vitrectomy, or you can just leave the capsule intact. And children with delayed milestones who may not cooperate later for AIOC capsulotomy, they will be ideal candidates to do a PPC even if they are older children. And also if there is a plaque in the posterior capsule, then it is better. So this is a slide showing how the visual axis, you can see the anterior rhexis margin as well as the posterior rhexis margin. And also you can have patients like this who present to you later on, with this kind of a fibrosed, this was a traumatic cataract, I think, so you can see the fibrosis. So sometimes if you leave the antivitreous phase, there will be lens epithelial cell migration, then the fibrosis will form on the anterior vitreous phase. So secondary operations like membranectomy have to be kept in mind. And inflammation, usually now, we used to keep these children for 2 days post-operatively, but now eyes are quiet. Older children, we discharge them the next day like adults. But we keep them in the hospital because it's under general anesthesia. We do not do cataracts at daycare, and most of our patients are traveling from different towns, so we keep them for a day. But younger children, less than 2 or 3 years old, and we keep them for 2 days in the hospital. We were discharging them, but then we burnt our fingers. We saw some of them coming after 2 weeks, like Dr. Meena showed, like with membrane and the Sinike and the resurgery after 2 weeks. So we try to keep them, because sometimes the child does not complain, they don't put the drops in the right time. So that is what will cause problems. And of course you treat them with steroid antibiotics, ointments in small children. We give atropine ointment for aphakics and homite drops for pseudophakic children. And this is for 4 weeks in tapered dosage. And the successful IOL surgery again depends on the selection of cases. I said up to the surgeon, the right IOL power, and keep the myopic shift in mind, choose the right formula, careful post-operative monitoring, and always look for the PC opacification. Most importantly, educate the parents regarding the follow-up and the refraction and the glasses. So the glasses usually will be given at the end of 4 weeks. So, and the gap between 2 eyes, we operate one eye, the other eye will be operated after 2 weeks. That is the norm we always follow, or after 10 days. And the follow-up will be based on the age of the child. Usually the younger ones, less than 1 year, we see them once in 3 months. Then after 2 or 3 years, we see them once in 6 months. After 5 years, we see them almost after 6 months till they are about 10 years of age, just to see if there is any refractive change, and check the IOP. And fundus evaluation is very important in these children. And also check for binocularity and intraocular pressure. It's very, very important in these children. So like I already mentioned about the follow-up, and if there's an underlying amblyopia, the treatment is usually with patching. Now vision therapy also can be tried. So to conclude, visual rehabilitation in pediatric cataract is separate thing. So you have to convince the parents and counsel them accordingly. Always try to achieve optimal visual outcome, adapt new visual abilities. That is good for the children to have a good quality life. It's a team effort and needs more than anything the patient cooperation. Thank you very much.